now I have the pleasure to introduce Professor Andrew Boulton. He's the past president of the European Association for the Study of Diabetes. The talk is about diabetic nephropathy, prevention, screening, and treatment.
Thank you very much. As I said yesterday, a pleasure to be here in this beautiful city. And when my slides appear, I will start. Looks like they're about to appear. Okay. This is a brief outline of what I will be saying in the next half hour or so. I don't need to tell you, because I told you yesterday, that the diabetes epidemic is ongoing, the 21st century epidemic, a very serious condition. And I show you this slide, which is from the Diabetes Atlas in 2011, because basically what they projected for 2030, we are there already, if the truth be known. Now, you just heard from Leszek in a very nice talk on diabetic retinopathy, the importance of screening. This slide emphasizes the importance of screening. If you see here on the left that because of our retinal screening program that is the envy of the rest of Europe, I'm told by Leszek, diabetes for the first time in the last few years is no longer the leading cause of blindness in England, because everybody has a letter from their GP once a year or from their optician. We have a retinal screening program where all patients are screened. Anything worrying, and this is read centrally by an expert, so they have a retinal photograph at their local optician. They don't need to go to their GP. This is read centrally, and any worrying features of retinopathy, they get an immediate referral. So this emphasizes the power of screening. In other words, secondary prevention. The patient already has diabetes. The secondary prevention is preventing the development of late complications. And the same is true for the kidney. So now we're going to focus on the kidney. It looks a bit like a boxing glove there, but it isn't. That's the kidney. And the importance of screening here, I cannot overemphasize. The consequences of diabetic nephropathy are horrendous. Now, we know from this study, just published a couple of years ago, that life expectancy is reduced by 12 years in those who have diabetes and cardiovascular disease. That's the bottom here, the bottom diagram there. But it's even worse in diabetic nephropathy. Diabetic nephropathy and mortality in diabetes, this is from the big Finn-Diane study led by our good friend Per-Henrik Group, former secretary, worked with me as program chair when I was president of EASD. And this shows on the right, if you've got end-stage renal disease, you've got a huge increased risk of mortality. And this has been known for many years. Here are data from the Pima Indians in Arizona, and there those with proteinuria and diabetes, again, a huge increase in type 2 diabetes in mortality. So chronic kidney disease is the major predictor of mortality in type 2 diabetes. And this study, published 10 years or so ago from Italy, shows the impact of macroalbuminuria on the right hand there, and if your GFR is less than 30, look at the huge increase hazard ratio there. Here again is a study from the South Tees study, that's in northeast United Kingdom. And this shows the impact of following 10 years of patients, again with eGFR of less than 30, you see the impact there on death, mortality. We know that end-stage renal disease incidence have been rising. They are curving off now in some countries, especially in type 1 diabetes, but because of type 2 diabetes, many patients are not diagnosed for the first 10 years, and they've already got renal disease when they're diagnosed, so it's not going to fall in type 2 diabetes for a little while. And here are the end-stage renal diseases due to diabetes in the United States until the year 2007. When I go to the dialysis unit in my hospital, I know half the patients there because diabetes is the commonest cause of patients ending up on dialysis. And I set up a combined diabetes renal clinic with nephrologists some 30 years ago in Manchester. We now have the largest combined diabetes renal clinic in the UK. So the combination, cardiovascular risk is greatest when you've got diabetes and chronic kidney disease, and the study from Foley from Canada suggests this here you see. So there's an added burden of chronic kidney disease on top of all the other problems of diabetes. You remember the Greek mythology, Sisyphus was a king who was punished by being compelled to roll this immense rock boulder up a hill, only to watch it fall back again, and he had to do this for eternity. This is the addition of chronic kidney disease to the other problems of diabetes. So what is the face of diabetic nephropathy, and how do we diagnose and classify it? Well, of course, as I said yesterday, we can envisage the retina non-invasively, as you just heard from Leszek. We can look at the kidney non-invasively because urine is the mirror of the kidney. And as I discussed yesterday, until we developed the corneal confocal microscopy, we could not see peripheral nerve in vivo. So normal albuminuria is defined as an albumin excretion rate of less than 20 micrograms per minute or less than 30 milligrams for 24 hours, or an albumin-creatinine ratio on the first morning sample. Microalbuminuria is a slight increase in this, defined there, and I'm sure you all know this, and macroalbuminuria is when you're dipstick positive. In other words, the albumin excretion rate is greater than 200 micrograms per minute or 300 milligrams per 24 hours. What about type 2 diabetes? Is microalbuminuria always diagnostic of kidney disease? Probably it may not be. This is work from our vice president of EASD, Paolo Fioretto, when she was working in the United States some 20 years ago or so. If you look at kidney biopsies, by the way, I would not advocate doing kidney biopsies, and we can discuss this at the end if you want. We rarely do kidney biopsies, but this was a study some years ago. Microalbuminuria in type 2 diabetes, unlike type 1 diabetes, where microalbuminuria is invariably due to diabetic nephropathy and the patients invariably have retinopathy as well, not so the case in type 2 diabetes. 30% may have near normal histology on a kidney biopsy. Only 30% will have typical diabetic nephropathy. And in type 2 diabetes, renovascular disease is common as well. And retinopathy may not always be present, and there are a number of reports to suggest that this is the case. And non-specific findings are often found as well. This is an old study looking at progression of diabetic nephropathy. If you've got proteinuria of more than 500 milligrams per day, you get progression of disease in terms of reduction of GFR. This is no longer the case with good intervention. Here's a nice study just published more recently, again from the Finn-Dayan study, looking at the impact of glycated hemoglobin and the standard deviation, in other words, glucose fluctuation. And at the bottom here, you see the most likely to progress are those who, as mean is above the mean glycated hemoglobin, in other words, you've got poor control, and it's variable, the standard deviation is above, and that's most predictive. So glycemic control does matter. And we know that intensive glucose control also reduces the risk of development of macroalbuminuria, and this summary and systematic review looking at a number of more recent trials and some of the older ones showing that intensive glucose control does also reduce not only the risk of microalbuminuria but of macroalbuminuria. So the natural history of diabetic nephropathy in type 2 diabetes, one sees functional changes, structural changes in some, rising blood pressure, microalbuminuria progressing to macroalbuminuria, rising creatinine levels, and end-stage renal disease. This is a natural history of untreated diabetic nephropathy. Now, today we widely use formulae to estimate the GFR. The original Cockcroft-Gault was 40 years ago now, and now we much more commonly use the eGFR or creatinine clearance, which is adjusted. So there are a number of different formulae, but all of you, I'm sure, are now talking about the estimated GFR, which how it is calculated, I will not read that out because it will use up too much time. But that's the eGFR that is a good measure of kidney function. But please remember the eGFR, like the blood glucose, is variable. I get letters from primary care saying, urgently see this patient because his EGFR was 80 and now it's 75. But you know, the next week it's probably going to be 80 again. So you need to look at the trend, not one or two readings. How do we define chronic kidney disease? Well, these are the stages of renal function as follows. And the ones that we generally worry about are stage 3, which is EGFR of 30 to 60 mils per minute, stage 4, which is pre-end-stage renal disease, 15 to 30, and less than 15 is defined as end-stage renal disease. But I would urge caution again that these are variable and never look at just one reading, look at a trend. And I think that we label too many people as having chronic kidney disease when they may well have normal function. And I'm especially referring here to the older population. Do up to 50% of the elderly population have chronic kidney disease if we go by these definitions? I would suggest that they certainly do not. Here was a nice study a couple of years ago looking at chronic kidney disease in the elderly. Is it disease or is it a disease label because we're using the EGFRs that are for the average middle-aged adult and not for the elderly? Remember that above 50% of patients over 75 will be defined as having stage 3 renal failure. Remember that in healthy patients, the GFR, renal function, gradually declines with age. And I think that the risk of end-stage renal disease is minimal in older patients with EGFRs in the stage 3 range, especially those 45 to 60. Epidemiological risk stratification is not suitable for that population, and I think you need to individualize. So I saw a patient in my renal clinic just before I came here on Wednesday. I was in my clinic. You know, a patient of 75, their EGFR is 46. I said, you don't need to worry. This is probably normal for your age. And I don't think you've got chronic kidney disease. And I suspect I'll be correct, but I can't prove that yet. So what is the prevalence of chronic kidney disease in patients with diabetes? And here's a nice study from Australia, some 10 years ago, just looking at a large number of patients, nearly 4,000 patients with type 2 diabetes. Around 53% of patients had normal renal function, and you see the percentages here with micro, macro albuminuria and what we would define as stage 3 kidney disease. What are the implications for clinical practice? Well, with declining renal function, please remember that many of the drugs we use, and we use many drugs, often I feel too many drugs in people with diabetes, many of these are primarily eliminated by the kidney. So one needs to look at all the medication load of our patients who have stage 3 or lower chronic kidney disease. Declining renal function decreases clearance rates and increases exposures and increases the risk of side effects. Several of our anti-diabetes medications should be avoided or used with caution in those with declining renal function. And remember that declining renal function increases the risk of severe hypoglycemia. And you see the bar on the left, this is the risk for severe hypoglycemia. If you've got chronic kidney disease and diabetes, there's a huge increased risk. Here are patients with diabetes without chronic kidney disease, and so on. So this is well recognized. Sulfonylureas cause hypoglycemia, and they're more likely to in patients with chronic kidney disease. So we need to balance the desire to lower blood glucose against the risk of hypos. And if you think about it, if you've got a patient who's already got, say, an EGFR of 30, they've got diabetic retinopathy, they're almost certainly going to have diabetic neuropathy, and they've got diabetic kidney disease, what is the advantage of driving the glycemic control very low? Probably very little. They're probably going to have loss of hypoglycemic awareness with long-standing type 1 diabetes, and the risk of hypoglycemia is much greater than the benefit that might be achieved, and that is dubious, by having tight control at that stage. We need to remember that. So the risk factors for hypoglycemia include all of these factors: age, gender, body weight, duration of diabetes, previous hypoglycemia, but renal dysfunction. Why are more hypos and why are they worse in people with with chronic kidney disease? Insulin half-life is prolonged in established renal failure. And don't forget, 20% of gluconeogenesis comes from the renal cortex, so you've got less glucose stores, impaired glucagon, impaired sensing, and so on. So don't drive the blood glucose too low in patients with chronic kidney disease. And here are some recommendations that many drugs should be avoided, and I think sulfonylureas should be avoided in patients with chronic kidney disease because of the risk of hypoglycemia. Biguanides I'll come back to because this has changed in recent years. DPP-4 inhibitors, some can't be used, but remember that you can use linagliptin. Linagliptin is entirely excreted in the biliary system, and the risk of hypoglycemia is very little in these drugs anyway, but it's absent in those with linagliptin and chronic kidney disease. So you can use that one safely. Here are some data from Australia that despite the advice, sulfonylureas are being used really very commonly in patients who have established chronic renal failure, and I would suggest that this is inappropriate. Metformin use as well. Okay, it's being reduced in those with less than 30 GFR. But what about metformin? Can it be used safely in patients with chronic kidney disease? This came up in discussion yesterday on one of my talks. And these are data from my good friend George Bakris, who's a true Greek origin character and a hypertension expert from Chicago, and Mark Molich. And this paper, just published last year, suggests that lactic acidosis is extremely rare, even in the elderly. Metformin can safely be used down to an eGFR of 30, and even the FDA have revised their restrictions, suggesting that this is indeed the case. In those with an eGFR of 30 to 60, perhaps some care with dosages, especially of other comorbidities, but you can use metformin safely in this group. I think its usage remains contraindicated in those with an eGFR in stage 4 or 5, less than 30, but I have to say that the evidence to support this statement is pretty weak. Pretty weak. This is mainly from expert opinion, which, as you well know, can often be wrong. So how do we approach diabetic nephropathy? What's your task as a doctor in the treatment of those with diabetic kidney disease? Now, untreated, this is a natural history, as I showed you earlier. And what we would love to do is to be able to reverse it, or at least stop further deterioration. And I have to say, it's been a pleasure looking after many patients in my diabetes renal clinic I've known for 30 years, and with aggressive control of blood glucose early on, but more importantly, aggressive control of hypertension. I still have patients now who have come to this stage here, and we've been able not to reverse, but to hold them, keep them away from dialysis. Life on dialysis, as I will show you, is no fun. It's a miserable existence. I would say that dialysis only keeps you alive while you wait for your transplant. That's what I would say. What about blood glucose control? I've suggested earlier that this may be important. And we know from the DCCT and the EDIC study that the fact that you've got better control, but despite the fact that control merged together during the epidemiology of diabetes and its complications study, and I'm privy to a lot of these data because I sat on their advisory committee and representing neuropathy, and it was very interesting to see the legacy effect. So intensive glycemic control continues to prevent albuminuria even during the follow-up study after 10 years of tight control. When control weakened or worsened, there was still this legacy effect. And the same was seen in our UK PDS in type 2 diabetes. Same. Here is the legacy effect here, again, after the UK PDS. Median follow-up, you can see in any diabetes-related endpoint and microvascular disease and others, you still have this benefit of a period of better control than the other group. Now, smoking. I must say, I'm surprised to come to here and find people smoking inside a hotel, and to find doctors smoking, which is worrying. And in Europe and North America, you cannot smoke anywhere. In America, you can't smoke within 50 feet of any airport door, so you have to stand in the highway, which would probably get killed by a car before lung cancer. But smoking is bad. And here are data from the FIN-DIAN study showing the effect of smoking on top of other features. And you see here in these lines, smoking leads to increased development of nephropathy. So the speed of kidney deterioration depends how many cigarettes you smoke a day. Best to smoke none. Blood pressure lowering, the most important fact. One of the most difficult things, I see patients who have had type 1 diabetes for 20, 30 years come into my renal clinic, and I say, look, you really need to focus on blood pressure. It's more important than blood glucose, and that's sacrilegious to them. They've been hammered for years, you've got to keep your blood glucose good. But blood pressure is more important. And what I encourage, and most of my patients in the diabetes renal clinic not only do blood glucose monitoring, they do blood pressure monitoring at home. And I would advocate the purchase of one of those small mobile blood pressure monitors that the patient can use at home. You see, the hypertension people are years behind us in diabetes, which is how I usually tease them. You see, we have glycated hemoglobin. They haven't got a glycated hemoglobin, which gives us 3 months of average control. So the hypertension people haven't got that. When my first diabetic clinic was 40 years ago this year, and people would come in and have a random blood glucose done, and I'd say, oh, you know, it's 6 or 120 milligrams percent. Right, well done, we'll see you in 6 months. We would never do that today. We have self-blood glucose monitoring, continuous glucose monitoring, we have blood pressure, glycated hemoglobin. But if you look at hypertension, they still do a random blood pressure in the clinic and increase the tablets on one reading, as we did 40 years ago. Their only measure, glycated hemoglobin, is heart attack, stroke, etc. So we're ahead of them. So we can do blood pressure monitoring, which is what I encourage, just like patients do blood glucose monitoring at home. The classic paper from Hans-Henrik Parving, who we recently made an honorary member of EASD, his wonderful studies in diabetic nephropathy over 40 years. This is the classic study of deteriorating renal function in terms of rising creatinine and albumin excretion and reducing GFR associated with high blood pressure. Intervene even late on and you reduce the rate of decline. Many other studies have shown this, and we use ACE inhibitors, angiotensin receptors blockers, and here is a study, there's a lot of studies over the years, captopril, reduced risk of developing diabetic nephropathy. ACE inhibition, again, microalbuminuria, the Benedict study. These are old studies, but they've shown that really, this is verapamil actually, and there is, versus trandelapril, a benefit there in both irbesartan, an A2 receptor blocker. All these studies show benefit. Losartan here in type 2 diabetes, preventing progression to end-stage renal disease in the Renal study. And these are classic studies, but they have informed our management of diabetic nephropathy over the years. Multifactorial treatment in type 2 diabetes, of course, came from the famous STAINO2 study. This was the first paper, and there's been a subsequent paper led by Olaf Pedersen, a wonderful diabetologist again in Copenhagen, who we've recently made an honorary member of EASD. And this is targeted, intensified, multifactorial intervention, the primary composite endpoint at tackling lifestyle, blood glucose, lipids, blood pressure, etc. And this shows how we should treat. We should try and get optimal blood glucose control to prevent diabetic nephropathy in type 1 and type 2 diabetes in the patient who doesn't have diabetic nephropathy. Stop smoking. Blood pressure. In microalbuminuria, I don't aim for the normal blood pressure. I aim for age-matched normal. So in a young person with microalbuminuria, we're looking at blood pressures going to about 120 over 75. It should be age-matched normal, lowering of blood pressure. And the proteinuric blood pressure should be even lower for those with proteinuria. ACE inhibitors and AR blockers, and of course lipid-lowering treatment as well. These are all important. Now, some patients will develop end-stage renal disease. And I have to say that we now have a conservative clinic, and that's not a conservative party clinic, a conservative clinic where older patients with EGFRs of 10 to 20 who don't want dialysis. They've been to look what it's like. They've talked to patients on dialysis. And with dietary modification, blood pressure control, we can hold people at that level without uremic symptoms for years. And I think that's a big step forward. Because, as I said, dialysis is miserable. Of course, the treatment options, number one treatment option is to prevent the end-stage renal disease by the interventions I've suggested. If you're there, then the renal transplant is the treatment of choice, and dialysis keeps you alive while you're waiting for that. And we use peritoneal dialysis, and we have a big unit for PD. We've got many patients on peritoneal dialysis. We use APD now, automated peritoneal dialysis, which is overnight. Some patients are still on continuous ambulatory peritoneal dialysis. Of course, the risk of infection and peritonitis is always there. We have home hemodialysis. We have some patients on home hemodialysis, but most patients have dialysis 3 times a week for about 6 hours, each of those 3 visits at the hospital dialysis unit. I would really advise you to look at this nice paper in the British Medical Journal in 2012. This is patients writing about what it's like to be on hemodialysis. This patient here, Mr. Evans, said being on dialysis isn't really a life, it's not even half a life. And this lady, a non-diabetic lady, she said dialysis is brilliant, of course, but deeply horrendous. And then, this is a non-diabetic lady watching other patients on the unit. On the dialysis unit, patients suddenly appear with amputations. But before that, they have heavily bandaged feet, rapidly followed by crutches, and then wheelchairs. This is the observation of someone with glomerulonephritis, looking at people with diabetes coming on, and that leads you into our work about the strong link between risk of mortality and risk of foot problems in those on dialysis. This is a series of papers we published a few years ago looking at foot problems in patients with end-stage renal disease on dialysis. We showed that dialysis is an independent risk factor for foot ulceration. And if you look at patients with end-stage renal disease not yet on dialysis, their risk of a foot ulceration is much less. Those on dialysis with a similar GFR compared with those not yet on dialysis have a 4-fold increased risk of foot ulceration. Mortality after amputation is extremely high, and we believe that there is a need for foot care on dialysis units. We see heel ulcers develop. Patients just sit with their heels for 6 hours, 3 times a week, and they end up with a heel ulcer. Because they're overwhelmed by the miserable feeling of being on dialysis, they forget about the feet because they don't hurt, because they have lost the gift of pain. These data are very worrying. This is mortality, dialysis, and foot ulceration of 192 patients we followed for 2 years. The 2-year mortality was half. Half of these are dead in 2 years. But if you've got an amputation and you're on dialysis, 3 out of 4 are dead in 2 years, 74%. These data are worse, as I said yesterday, than almost every form of cancer. So we've got to take diabetes seriously. And remember, if you're on dialysis, you don't need to examine the feet to see if they're at risk. They are at risk. You need to examine the feet to prevent problems developing. And they need to have education and so on. So we have renal replacement therapy. The best is transplantation. I've got some patients now 30 years after a transplant with normal renal function. In my combined diabetes renal clinic on Wednesday, I saw 3 patients in one morning who had simultaneous pancreas kidney transplants, doing very well with normal renal function and normal blood glucose control after this combined transplantation. That's not the preferred treatment, though. The preferred treatment is to prevent diabetic nephropathy from developing at all. So the take-home messages you already know about diabetes is increasing. Here, that's certainly true. Diabetic nephropathy is common. The consequences are grim if left untreated. Screen for diabetic retinopathy, of course, and for diabetic nephropathy. They tend to go together. And both can be treated and prevent progression by early screening. If you get patients with microalbuminuria, hammer the blood pressure down to normal, the chances of them progressing are markedly reduced. So it's early and aggressive multifactorial treatment. And remember, microalbuminuria is not just a test result you file in the notes. It's a call for action, intervention, and prevent progression to something which is miserable. So here's a quotation: some people make things happen, some people watch things happen, some people wonder what has happened. Let's go to the top and make things happen, because we can reduce the incidence of this terrible complication by early screening and intervention. Shukran.
Thank you, Professor Andrew, for this useful and practical lecture. And if there is any question or comment, please, Doctor. Okay.
Thank you, Professor Andrew, for your elegant lecture. I want to ask about if a patient with type 1 diabetes developed micro or macroalbuminuria, what is the action? What is the action I must do?
What is the action?
Yes.
What do you mean by the action? What should we do?
Yes.
Oh, what should we do? Right, okay. If you've got someone with type 1 diabetes develops macroalbuminuria, the studies from Denmark and from guys in London in the 1980s show at this stage you may be able to reverse it. So at the stage of microalbuminuria, there's no doubt in type 1 diabetes that glycemic control is extremely important. So we should be aiming for near normoglycemia, gradually achieving it, never make sudden changes. And these days, in our type 1 diabetic patients, for such a patient as that, they would have reimbursed continuous glucose monitoring. So this is very helpful. So we can go for good glycemic control. Again, any elevation of the cholesterol, I think all these patients should probably be on a statin. And thirdly, even if they've got normal blood pressure, I would put them on a low dose of an ACE inhibitor, because we know that ACE inhibitors can reverse macroalbuminuria. So although I cannot prove that all three together works, as they have proven from the Steno in type 2, I think this would be my approach at that stage in type 1 diabetes. All three.
If the patient is normotensive, just microalbuminuria,
I think that
should I begin?
I think some of my colleagues, and probably I as well, would put a patient on a low dose, perhaps enalapril 2.5 milligrams a day, because the evidence is strong for reduction of microalbuminuria with ACE inhibitors.
Yes. What about statin?
Statin, again, if there's any suggestion, and I think most patients at this stage with type 1 diabetes are going to have a slightly borderline cholesterol, and I think a low dose statin is indicated.
At which age? The same
Well, I only see adult patients, so I don't mind what the age is. If the cholesterol's high, I put them on a statin. I can't say about teenagers and children because I'm not I'm an adult physician.
Usually begin it after the 12 years old. I talk about younger than 12 years old. It is
younger than 12 years old, I wouldn't like to comment, because it's extremely unusual to see macroalbuminuria in that group. And I think one would be much more careful in that age group with a statin, certainly.
Thank
you. My question about, about SGLT2. You know that after the development of these new drugs, they are focused in sodium reabsorption and increased intraglomerular pressure.
Which one? SGLT2s?
Just, yeah.
Yeah, I think SGLT2s will not work in patients with established renal failure, so we don't use them. But I think earlier on, I have no objection to their use, because they help with weight loss and they help with high treatment of blood pressure as well. And I think even though there are very few studies in nephropathy, there are one or two that suggest benefit. So early on, but if you've got established renal failure, they're not going to work. I think this gentleman had it, yeah.
Thank you for the lecture. Would you comment on the addition of vitamin D? Vitamin D.
Vitamin D?
In addition to ACE or ARBs?
I think that vitamin D deficiency is common,
some studies show that,
especially in Manchester, where we don't have such good weather as here. So I think that vitamin D should be corrected if there is a deficit. But then, of course, in end-stage renal disease, we get into a very complex area with primary, secondary hyperparathyroidism and so on, while calcium metabolism is affected, and phosphate, high phosphate, we use phosphate binders. But that's a different, I don't think you're asking about that. I think you're asking about earlier on.
About diabetic nephropathy with normal kidney function. Just
normal kidney function, we do. We give many patients vitamin D supplements.
Will decrease the proteinuria.
Yeah, we give many patients vitamin D, yeah.
Separate studies.
But later on, I think we've got to be very careful, because of metabolic bone disease, we've got to be very careful what we use.
Yeah. Second, comment about addition of renin inhibitors or endothelin antagonists. Endothelin.
Okay, if you're asking about
proteinuria.
we used to use a combination of ACE inhibitors and ARBs, but recent data suggests that that may not be such a good thing. So we rarely use those together. I've got hardly anybody.
No, this other than that. A contraindication of giving ACE inhibitors and angiotensin receptor antagonists.
Okay,
but
well, contraindication.
Other inhibitors.
Yeah, I think that I have to say, having done a renal clinic for 30 years, I used to worry about a potassium of 5.5 to 6, but I don't worry about that too much these days. The laboratory will ring and panic. This patient's potassium is 6.2. So we've got to be careful with potassium. And in some patients, in type 2 diabetes, especially if there's peripheral vascular disease, there could be renal artery. That wasn't me? No. There could be renal artery stenosis, and in which case you should not use those drugs because it drops intraglomerular pressure, and that would be dangerous. So you've got to be very careful in some patients who are vascular paths, as we say, with multiple vascular disease, about using those drugs because of the risks there.
I'd like to ask about the lowest level of blood pressure, because there is a J-shaped curve between blood pressure control and progression of renal disease. What is the suggested lowest level to bring blood pressure down to?
I think what we aim for, especially in type 1 patients, type 1, because of course the further north you are in Europe, the more type 1 patients you have, so we have a large population of type 1 patients in my diabetes renal clinic. We aim for age-matched normal. So it depends on the age group, the age-matched normal. I think there are dangers in older type 2 patients to drive the blood pressure too low. And, has to think about individualization. If you've got someone who's 75 living alone, then the dangers of dropping the blood pressure and postural hypertension, a fall at home, a fracture, then that's it. So I think you need to take into account the age and the type of diabetes.
I'd like to ask about organ transplantation associated diabetes, especially after renal transplantation. If there is any guidelines regarding adjustment, immunosuppressive doses, if the patient developed diabetes?
I'm sorry, I couldn't get... You're asking about post-renal transplant?
Organ transplanted associated diabetes. If the patient developed diabetes...
Secondary diabetes. Oh, okay. Yeah, I saw in my clinic on Wednesday, I saw 2 cases of secondary diabetes, and we know that the calcineurin inhibitors, that anti-rejection drugs, can bring on diabetes themselves, but I would much rather have secondary diabetes and normal renal function. So we know that, NODAT, new onset diabetes after transplantation. There was a symposium on that some years ago at the ADA, a very good one. And these patients have insulin resistance, and they need to be treated because I have to say, and I didn't say before, so thank you for bringing it up, after you've had a renal transplant, glycemic control becomes very important again because of the danger of developing transplant diabetic nephropathy, which we see. So glycemic control is important, and we see a number of patients who get secondary new onset diabetes after transplantation, and we treat them as we'd treat any other type 2 diabetic patient. And these need to be going for near normoglycemia to prevent transplant nephropathy. We use any of the agents, we use insulin, whatever's needed.
What about the immunosuppressive after?
Oh, immunosuppressives, well, we don't meddle with that. The immunosuppressives are essential. And some patients still have steroids if they've had a rejection episode, and I have patients, for example, on mofetil, whatever it's called, mycophenolate mofetil, MMF, tacrolimus, and prednisolone. Okay, they get secondary diabetes, but their kidney function's normal. It's better to treat the diabetes than to fiddle around with the anti-immunosuppressives and lose the kidney.
I want to ask, is there any preference to ARBs over ACE inhibitors in diabetic nephropathy? And is there any preference of a special drug?
I think that almost all of the drugs have been studied. And if you look at all the trials, we've got captopril, enalapril, lisinopril, losartan, irbesartan, they've all been studied and they all are effective. So I can't say because this patient's type 1 with this level of albuminuria, I'm going to give him perindopril or lisinopril. I think that you'd use the one you're familiar with and it works and that has least side effects. We do get cough in a number of patients on ACE, so we put them into ARBs such as candesartan or something like that. But they're all pretty effective.
Yes. Another debatable issue, kidney biopsy in
yes, thank you, yeah. Kidney biopsy. I would say that I hardly ever do a kidney biopsy in the diabetes renal clinic. If someone comes to me, number one, type 1 diabetes, they've got retinopathy, they've got proteinuria, we do a renal ultrasound, we perhaps do some immunology, and the ultrasound's normal, immunology is negative, no indication for a biopsy. That's going to be diabetic nephropathy. Every biopsy has a risk, and there are risks. It's quite invasive, there are risks of bleeding, and so on. Type 2 diabetes, if the patient's got renovascular disease, again, we would not normally do a biopsy. They usually have some proteinuria, again, ultrasound, immunology. Now, I have picked up a couple of abnormal ones. We had one lady who came in, and if there's ever any hematuria or even microscopic hematuria, look for another cause. We've had 2 hypernephroma turn up in the diabetes renal clinic, had proteinuria, but also hematuria. That was picked up on an ultrasound, then arteriogram. So they were removed and they're still fine. Again, atypical diabetic nephropathy, that is, if there's little proteinuria, rapid progression, atypical renal size on the ultrasound, then I have a nephrologist, we sit together in the clinic, and then we would consider a biopsy. But I would suggest, we've got hundreds of patients, so we've done no more than 10 or 20 biopsies over the last 15 years, I would say.
We see many diabetic patients who develop rising creatinine without the presence of the proteinuria. Is this an indication, this is not the usual course?
If there are atypical features, then one would consider carefully a biopsy after other less invasive investigations, including a renal ultrasound is very helpful. We rarely do an intravenous pilot IVU or IVP, whatever you call it.
Thank you.
Thank you for your elegant lecture. I ask when you are defining stages of CKD, stage 2, certain GFR, and persistence of proteinuria. If proteinuria is improving, what's the stage next? The GFR is the same, but proteinuria improving.
Okay,
what can it
yeah.
do?
I mean, proteinuria doesn't always follow progression. And proteinuria may be high, and we still see, although I must say I see much less nephrotic syndrome than we used to, probably because of good control and good blood pressure control. We still see nephrotic range proteinuria occasionally, especially in type 1 diabetes. I think the GFR, we say stage 2, but stage 2 is basically normal. And I think there are dangers of saying you've got stage 2 and not stage 1, because the patient may be labeled as having some renal disease when in fact they have not. And I think we look at the combination of the two and how they vary. So if you've got someone with proteinuria and it's, say, 2 grams for 24 hours, we put on an ACE inhibitor to tighten the glycemic control, that reduces to microalbuminuria, then we're quite happy. And we treat the blood pressure, we treat the blood sugar, and hopefully the GFR will not go down. But, you know, to say this patient, oh my God, they've gone from stage 2 to stage 3 because they've gone from 61 to 59 is nonsense. And I think it's a variable and it's going to go up and down. And watch the trend and don't just look at 1 or 2 readings. And that's true for most of medicine. It's common sense approach.
Thank you very much, Professor Boulton, for